Good morning. Welcome to today's case presentation. Presenting a 60-year-old male patient hailing from Thrissur, farmer by occupation. He presents with a history of a swelling over left knee since 1 month. The patient noted a swelling of the size of a peanut over the inner side of the left knee. Initially, it was not associated with any pain. The swelling gradually increased in size and reached to the size of a lemon, and it was associated with pain that is throbbing in type 2 weeks back. The pain was mainly during the night time and was aggravated during exertion. He is a frequent cycler, and his pain was elicited on cycling. The pain was relieved on analgesic. There is no history of any fever. There is no history of any loss of weight. There is no history of any trauma, and there is no history of any other swellings in the body. Coming to the past history, there are no history of similar swellings in the past. There is no history of tuberculosis in the past. There is no history of diabetes mellitus, hypertension, and coronary artery disease. General examination was within normal limits. Coming to the local examination of the swelling. On inspection, I could appreciate a single spherical swelling of approximately 4 to 3 centimeter situated on the medial aspect of the left tibia. It was extending vertically downwards, approximately 2 centimeter below the medial joint line, and horizontally to the medial side, approximately 1 to 2 centimeter medial to the tibial tuberosity. On inspection, the surface of the swelling appeared smooth, and the edges of the swelling appeared clearly defined, and there was no visible pulsations, no scars, sinuses, dilated veins, and the skin of the swelling or the swelling appeared to be normal. Coming to the palpation, there was no local rise of temperature, there was no tenderness. The swelling was of 7 into 5 into 3 centimeter, single spherical swelling, located 1.5 centimeter from the tibial tuberosity, approximately the 3 centimeter from the medial joint line, and 2 centimeter from the inferior pole of the patella, and 4.5 centimeter from the patellar tendon. The surface of the swelling appeared smooth, and the edges of the swellings are clearly defined all out, and the swelling was firm in consistency. It was non-fluctuant, non-compressible, and non-translucent, and the slip sign was negative. No palpable pulsations, and the skin or the swelling was pinchable. Coming to the mobility, the swelling had minimal longitudinal and transversal mobility when examined in the extended position of the knee, but became more prominent and fixed when the knee was flexed. On flexing, the swelling was more prominent and sir, I'm presenting a 60-year-old male patient who presented with the swelling over of the inner side of the left knee since 1 month duration. There was a increase in the size of the swelling over 2 weeks with associated pain, the throbbing type of pain. And on examination, on inspection, it was a single spherical globular swelling of 4 to 3 centimeter with a vertical extension of 2 centimeter from the medial joint line and horizontal extension to the medial side of 1.2 centimeter medial to tibial tuberosity. The surface of the swelling appeared smooth, and the edges were clearly defined. There was no visible pulsations, scar, sinuses, or dilated veins. Palpation, there was no local rise of temperature or tenderness. 7 into 5 into 3 centimeter single spherical swelling. It was located 1.5 centimeter from the tibial tubercle, 3 centimeter from the medial joint line, and 2 centimeter from the inferior pole of patella, and 0.5 centimeter from the patellar tendon. Surface of the swelling was smooth and edges clearly defined, and it was firm in consistency. It was non-compressive, non-translucent, non-fluctuant, and the slip sign was negative. There was no palpable.
Abhilash, I had an objection. I don't think it is firm. It is tense and twisting. That is what my impression was even from the beginning. I was rather confident that it was twisting. That's why in fact, I neglected even the MRI fine. You cannot, you will not appreciate the tense cystic feel.
സാർ സിസ്റ്റിക് ആയിട്ട് ഫീൽ ചെയ്തില്ല സാർ. ഇപ്പൊ സിസ്റ്റിക് ആണെന്നുണ്ടെങ്കിൽ കൺസിസ്റ്റൻസി ഓഫ് ലിപ്സ് എന്നല്ലേ പറയാം സാർ, അങ്ങനെ തോന്നിയില്ല സാർ.
It's okay, but I was rather confident. That is why I proceeded with the surgery also. Anyway, to me it looks like very cystic, tense cystic cell. Okay.
സാർ സിസ്റ്റിക് സെല്ലിങ്ങിന്റെ വേറെ ഫീച്ചേഴ്സ് ഒന്നും കിട്ടിയില്ല സാർ, ട്രാൻസ്ലൂസൻസി അങ്ങനൊന്നും കിട്ടിയില്ല സാർ.
നമ്മള് അത്രയും തിക്ക് ഫ്ലൂയിഡ് ആകുമ്പോൾ ഉണ്ടാവില്ലല്ലോ. പക്ഷെ സെൻസിറ്റിക് ആണ്, അത് ക്ലോസ് ഫ്ലക്ച്വേഷൻ കിട്ടിയെന്നാണ് എനിക്ക് തോന്നുന്നത്. ഗാംഗ്ലിയനിലൊക്കെ കിട്ടണ പോലെ ഗാംഗ്ലിയൻ ഇറ്റ് വിൽ ബി ഫേം, but still if you carefully look for the fluctuation, you can elicit fluctuation just like that. Okay.
Okay, sir. Sir, coming to the examination of the knee joint, on inspection, there was a bilateral genuine valum more on the left side. There was no hamstring, cortices, or gastrocnemius, gastrosoleus muscle wasting. There was no other swellings around the knee joint. There was no deformities. Sir.
You should comment about the scars. So swellings and wasting, scars and sinuses, deformity. These are the 5 things you should at least comment in any inspection.
സാർ ഇപ്പൊ ഇൻസ്പെക്ഷൻ ഓഫ് സ്വെല്ലിംഗിൽ ഞാൻ സ്കാർസിന്റെ കാര്യം പറഞ്ഞായിരുന്നു, അപ്പൊ ഇതിവിടെ റിപ്പീറ്റ് ചെയ്യണോ സാർ?
Inspection of swelling is at a small area. You are inspecting the entire knee joint. There will be scars somewhere, so that should be in your mind. And scars can sometimes make you faint, so that should be always in your mind.
Okay, sir. And coming to the palpation, there was no medial or lateral joint line tenderness. The both the femoral condyles and the tibial condyles appears normal. There was no tibial tenderness of the tibial tuberosity, and the popliteal fossa appeared normal. There was no palpable pulsations or no other swellings around the knee, and the range of movements were flexion was from 0 to 120 degree. There was no features of varus or valgus instability or no ligamental laxities, and the patellar tap was negative. There was no synovial thickening. On the opposite knee and the same side hip was within normal limits.
Orthopedic examination is never complete without telling 2 more things.
Sir, pulsations, distal pulsations,
and neurovascular status of
neurovascular.
Okay.
What about the relationship to the surrounding structures? For example, what is the surrounding structure you expect?
Sir, the surrounding structures are the ligamentum patellae and the anserine bursa and the patella proper and the medial joint line, sir.
What is getting inserted around the bursa?
Sir, the superficial to the bursa, there is a conjoint tendon of sartorius, gracilis, and semitendinosus, and deep to the bursa, the medial collateral ligament is inserted, sir.
Okay. What are the tendons getting inserted? This called, what is the other name of that?
Pes-anserinus.
So that include what all structures?
Sir, semitendinosus, sartorius, and gracilis, sir.
So it is SGT, sartorius, gracilis, and semitendinosus. So which all nerves are supplying these muscles? Just asking you. That is not related to this case. I think we will discuss it later. Okay. We can continue the presentation.
Summarizing my presentation.
No, what is the relationship of the pes anserinus? What is the muscles of the these three.
Sir, according on there there was minimal longitudinal and transverse mobility in when the knee was examined in extended position, but it became more prominent and fixed when the knee was flexed.
To become fixed. What does it mean?
Sir, it appears so the plane of the swelling is deep to the deep fascia and appears to be arising from the conjoint tendon of the pes anserinus, or maybe
Sir.
deep or maybe from the bursa of the pes anserinus.
So, from the clinical examination, what is your feeling? Is it a swelling arising from the bursa of the pes anserinus, or
Sir, my first diagnosis will be a pes anserinus bursitis, sir, because of the location of the swelling.
location of swelling? From the relationship of the muscles, can you come out with some? Is there any point in favor or against from the palpation of the structures, or how you?
If it was to be arise from the tendon, sir, when we flex the tendon or contract the muscle giving the tendon, the swelling should get fixed.
So how do you make the tendon taut?
Sir, these muscles are mainly extensors of hip and flexors of the knee. So we flex the knee against resistance so that the muscles contract.
Which one is the flexor of the knee?
Sir, semitendinosus is the flexor of the knee, and gracilis is the adductor of the hip.
Is the semitendinosus flexor of the hip?
Sir, semitendinosus is arising from the ischial tuberosity, sir. So it is crossing two joints.
Right. How can it become a flexor?
It is not the flexor of the hip, sir. Extensor of the hip and flexor of the knee, sir.
While which one is hip, flexor of the hip?
Flexor of the hip is the iliopsoas.
Iliopsoas. No, that is not coming to this. Of the three tendons in the pes anserinus, what is the which can be a flexor of the hip?
Flexor of the knee is the semitendinosus, sir. It comes under the hamstring.
You are saying about the flexor of the hip.
And flexor of the knee, sir.
Yeah. Is there any muscle which can act as a flexor of the hip?
Sir, sartorius, sir.
Sartorius. What is the action of sartorius?
Sartorius flexes the hip and flexes the knee, sir.
I think there is some more details about the action. I വായിച്ചിട്ടില്ല അല്ലേ അത് എക്സ്റ്റെൻഡ് റൊട്ടേറ്റ് ചെയ്യുമ്പോൾ ഫ്ലക്സ് ചെയ്യാൻ അങ്ങനെ ഒരു ആക്ഷൻ ഉണ്ടാവില്ല. ഇറ്റ്സ് നോൺ ആസ് ടൈലേഴ്സ് മസിൽ അങ്ങനെ പറയും അല്ലേ?
Sartorial means tailor.
Yeah.
Tailor's muscle. What is anserinus? Yes, anserinus.
Yes, sir.
What's the meaning? What do you understand?
Sir, goose feet, sir. It appears like the feet of the goose.
Yeah, that's it. Pes is foot and goose-like or a duck-like feet, because the insertion of the tendons of the sartorius, gracilis, and semitendinosus is more or less in that fashion. Anatomists used to describe it according to the existing fashion. That's it. And of course, gracilis is actually supposed to add beauty to the eye of the female. That's why that word gracilis took on it. So, sartorius is a tailor's muscle. Gracilis adds to the beauty of the thigh, if you want to imagine that way. And then pes anserinus is the foot of the goose. So these are some of the anatomical features of those muscles. So when you are asked to comment about the presence, you are presenting with a soft tissue swelling on the inner aspect of the upper end of the medial aspect of the tibia. Could you enlarge that picture a little bit? Left side, is it? Yeah. Could you enlarge it a little bit?
Have you? I have got another picture. Have you incorporated that? And yeah. So they have got another pictures also. Yeah.
Yeah, it's fairly big now, actually.
Mm.
Okay, is it something congenital, developmental, infection, inflammation, tumorous conditions?
Sir, giving the short history and on examination, it appears to be a benign lesion. It favors to be an inflammatory condition, sir.
Right, because whenever you get a problem, you have to have the mental picture of the orthopedic conditions that can present it. We used to discuss it in 7 headings: congenital, acquired, developmental, etc., etc. I don't want to go into those things again. Doesn't fit in with a neurological condition, doesn't fit in with a traumatic condition. So you have to consider the possibility of an infection, an inflammation, or degenerative condition. A tumor should never be forgotten because it can be a soft tissue tumor as well. So these are the things we considering the fact that it is about 3 weeks duration. Most likely it looks like a bursa. I don't know, it may be. But there are multiple swellings or not?
Sir, there is only a single swelling, sir.
Single swelling. In the distribution of and the attachment of the pes anserinus, is it?
Yes, sir.
Knee joint is free.
Yes, knee joint is free, sir.
There is no patellar tap, there is no fluid inside the knee joint.
No, sir, no fluids. Only finding was a genuvarum, sir.
Kishore was asking you what's the neurological status. Is there what nerve is likely to traverse through that area on the medial side? Which when we were students, we were asked that question quite frequently because we were doing meniscectomies open. Which nerve, cutaneous nerve, is likely to
Sir, saphenous nerve, sir.
saphenous? It's actually it's actually good that if you put an incision over that, you may cut that nerve. So that's very important.
Sir, infrapatellar branch of saphenous nerve, sir.
Branch of the saphenous nerve. That is the correct answer because whenever we were making an incision for a medial meniscectomy, it's an oblique incision, and we were warned to take care of the cutaneous nerve, infrapatellar branch of saphenous nerve. With the advent of the arthroscopy, that particular nerve has disappeared into oblivion. Nobody is asking that question these days. But you should be aware when you are going to expose this kind of a swelling for whatever reasons, surgically or otherwise, you should be familiar with that. So now you should tell us the diagnosis, differential diagnosis.
Because all the 3 muscles that's coming to that insertion have a different action. They are coming from the 3 compartments. One is coming from the anterior compartment, one is coming from the medial compartment, and the other one is from the flexor or the posterior compartment. So, is there any way of finding, making it taut? Anyway, that is not easy. That is why I am telling. Because you can make the semitendinosus taut. Is of the 3, semitendinosus is the posterior or anterior? What is the relationship?
Posterior, sir.
Posterior. So the posterior border you can very well make out, but the anterior border very difficult. Even the gracilis. What is the action of the gracilis?
Sir, adductors of the thumb. Adductors of the hip, sir. Adductor of the hip.
Yeah, it is adductor of the hip. Yeah, but so it is very difficult to make it taut at its insertion. But only way is to make the semitendinosus taut. So you can feel the posterior border. Have you palpated it and made it taut and found out the relationship?
Sir, അങ്ങനെ ടെൻഡൻ ആൻസറിംഗ് ബസ്സിൽ പാൽപ്പേറ്റ് ചെയ്യാൻ പറ്റുന്നില്ല സാർ ഈ സ്വെല്ലിംഗ് ഓവർലേ ചെയ്യണോട്ട്.
No. You can very well palpate the posterior border of the semitendinosus. The border you can make the semitendinosus taut. In this case, I have done that, and it is quite free. That it is just anterior to that. It is not overlapping the semitendinosus. In fact, you can call it as it is becoming the swelling is becoming a little more prominent. Yeah, it is not underneath that we can say. We cannot clearly say whether it is deep to the sartorius, it is very difficult to make it taut because the action of the sartorius over the knee is very less. Okay, but semitendinosus is a very good flexor of the knee, so you can make it easily taut. Anyway, your examination will not be complete without telling that finding also. Okay.
Okay, sir.
Okay, now. Can you feel any bony irregularity underneath? Have you palpated that?
Sir, ഇല്ല കിട്ടിയില്ല sir.
ഞാൻ
Sir, I was not
Yeah.
able to insulate under the swelling, sir.
insulate.
Sir, sir, I was not able to go under the swelling. Only the edges were palpable, sir. Sir, medial tibial condyle palpate ചെയ്യാൻ പറ്റുന്നുണ്ടായിരുന്നു.
But I think I have shown it to Tony also. I think just along the border, if you can palpate the tibia at a particular area, there is a depression. Tony അത് കണ്ടിരുന്നില്ലേ? അത് പെറോപ്പറേറ്റീവിലാണ് നമ്മൾ കണ്ടുള്ളൂ.
സർ പെറോപ്പറേറ്റീവില് നന്നായിട്ട് കണ്ടിരുന്നു.
ബിഫോർ സർജറി നമ്മൾ പാൽപ്പേറ്റ് ചെയ്ത് തോന്നിയില്ല. ഞാൻ കാണിച്ചില്ലായിരുന്നോ? Okay, you proceed.
That finding is very important.
So ultimately, what do you feel? Is it a bony swelling?
No, sir. It is not a bony swelling, sir. It is arising from the soft tissue. Sir, my first, I don't have a definitive diagnosis. I have a differential diagnosis.
The patient is having night pain, like.
Yes, sir.
Is that a night pain? Is it a significant symptom or an insignificant symptom?
Sir, night pain is seen in a tuberculosis condition. Usually,
what does night pain signify?
The muscles get contracted and confined the swelling, but during night, when the muscles relaxes, the pain develops, pain increases.
Somebody is having back pain, somebody is having hip pain, and you ask about night pain. If that is present, will you give extra care for your further examination or not?
Yes, sir. If it is an inflammatory condition, there will be rest pain.
What are the 2 or 3 possible diagnoses if there is night pain, which are serious conditions?
Sir, inflammatory conditions, then osteoidostoma, so benign neoplasm.
No, I am asking about a general diagnosis, not necessarily for this patient only. If the patient is
Sir,
having
inflammatory and
night pain,
neoplastic conditions.
inflammation, neoplasm, and one more thing, infection.
Okay, sir.
These 3 things should be kept in mind. Okay.
Tumor, tuberculosis, and infection. Those are the 3 diagnoses which you should never forget. Infection in the first order, tuberculosis in the second, and tumors are the third. For infection, tuberculosis, and tumors. The problem is actually the so-called night cries were described when tuberculosis of the bone and joints were rampant, because when the patients try to sleep, the muscles are relaxed, so the irregular destroyed joints or fissures are up against each other, and therefore it initiates a suction episode of successive episodes of spasm, and the patient actually wakes up with pain. That's one reason. Whereas with the tumors, it is actually tension the whatever soft tissue structure and the periosteum, which again makes it painful. In infection, naturally, the throbbing vasculitis, whatever inflammation, is causing pain. So this must be the reasons why patients get pain, and that actually disturbs their sleep. So the question which actually Dr. Kishore was pointing at, does the pain interfere with your activities? That means the question which you should ask is, what are things you can't do now because of the pain, which you were able to do in the past? That's a significant question. Because what all things you can't do, which you were able to do in the past before the onset of pain. That's number 1. Number 2, whether the pain disturbs your sleep at night. Those are 2 important questions which you should never forget when the patient presents with pain in an orthopedic problem. Carry on.
What kind of tumor you will suspect if there is night pain? Benign tumor or a malignant tumor?
Sir, most commonly it is associated with an osteoidostoma.
No, a malignant tumor or a benign tumor in general. Night pain.
Sir, benign tumor. Sir.
Night pain.
Glass. എപ്പോഴും പറയാറുള്ളതാ.
We are more in towards a
Sir,
malignant tumor.
malignant.
That is just a rule of thumb. That does not mean that all patients with night pain are having malignant tumors, but that should be kept in mind. Okay. So only thing that is not fitting into your diagnosis is the night pain. Why the patient is having night pain?
Sir, it is an inflammatory. My first differential diagnosis is presencerin bursitis, so it is an inflammatory condition. So that may be associated.
So is it infected?
Sir, infected. There was no loss of temperature, no tenderness.
If there is infection, you can have night pain. So a bursa which has got infected, you can have night pain. Otherwise, a simple bursa, can it produce night pain? I don't know.
So why it is not arising from the bone? You have to tell that.
Sir, it is not imperceptibly merging with the bone, sir.
But you can insulate. That's what he said. Right?
Yes, I can insinuate my fingers in the all around the edges of the swelling. Sir.
Okay. Then the consistency.
Consistency of the swelling.
Bony consistency. So, what is your diagnosis?
Sir, I don't have a definitive diagnosis. My first differential diagnosis will be a presencerin bursitis, and I also have a second diagnosis in mind, that is a ganglion arising from the tendon sheath.
Which tendon sheet? Which is tendon sheet?
Sir, it is it inserts as a conjoint tendon over the presencerin bursa.
So if you are telling there is a reason on the tendon sheet, there must be a sheet for the synovial sheets for some tendons there. Is there any synovial sheets for the three muscles you have mentioned? I don't think so. In fact, it is the presencerina that acts as a lubricating thing, not the individual tendons are not having synovial sheet, as in the case of a extensor or flexor tendons of the fingers on the wrist. So if you are telling it is arising from the tendon sheet specifically, then it is very difficult to substantiate because there is no tendon sheets for the tendons. The work of the function of the presencerina, bursa of the presencerina, is that of a tendon sheet. The bursa that is functioning because there are three muscles coming from different directions and it is attached to the bone. So there will be friction between these three tendons which are acting in different directions. That is why there is a bursa there.
Yeah, it is certainly a bursitis, not a tenosynovitis, no doubt about it.
So it's better not to tell that diagnosis as a tenosynovitis. Okay. So it can be, it is a ganglion. Don't tell it is arising on the tendon sheath. It may be a ganglion, maybe attached to the joint itself. So
Sir, there are some features of communication to the joint, sir.
There is no features there.
Sir, no features.
There is no feature. What is the finding that tell you that it is communicating? It can be communicating.
Sir.
What specific
Sir, there can be a movement restriction.
No. Usually, for example, that is most common in the lateral meniscus. Tony can tell. What is that? Tony just tell. What is the finding that tells it is saying it's a swelling? Yes, a swelling similar to that. A cystic swelling. എന്താണ്
meniscal cysts are flexing, decrease in size.
Yeah. So with different movements of the especially in extremes of flexion and extension, which become very important. While in the middle portion, it becomes less common. That is the classical finding of a cyst of the lateral meniscus. It's usually that the changes occur mostly in the lateral main. So, in this case, there is no change in the shape size of the swelling, which is the point in again. But does not mean that it is such a big swelling. You can appreciate the change in the size. So, but the classical description is if there is a change in size with the movement of the knee, then it is it is arising in the intra-articular structure like this. Okay. So we can tell that because of the size of the swelling, it can still be a intra articular or articular meniscus again.
I understand undergraduates are also listening, is it? So many new names are seen.
Yes, sir. The house ends are there. Today onwards, house ends are also joined.
Oh,
You have roped them in, rather.
Actually, they were running around, so I just wanted to make them sit.
You have angered them. The simple thing is the swelling increasing in size or is there any size variation? When you flex and extend the knee. That's the simplest way to say that it is communicating with the joint. So you bend and extend the knee. If it is increasing or decreasing depending upon the nature of the joint movement, the motion, then it is a communicating with the joint. Unless, of course, the fluid is so tense that it has no place to move, then the joint also will be showing evidence of effusion. So in this case, if it is not showing any difference in movement size, when you extend and flex the knee, then it is extra articular and it's not connected with any joint. So that's what the meniscus usually comes in because that is meniscus is moving inside the joint. I mean, it is related to the movements of the joint. So you will have a difference in size. That's all I wanted to convey.
Okay, so there are few diagnoses because one is the present stage of ulcer. But I feel because the meniscus it has become so large. Okay. So how will you confirm your diagnosis?
Sir, I would like to investigate the patient. First, routine blood investigations, including total count ESR, which was in normal limits. The total count was 6,800 and ESR was only 3 millimeter. So there was no any features of any infection based on the laboratory findings. And I took an X-ray of the knee joint, and lateral view. It was showing an eccentric lytic lesion in the medial tibial condyle, or which the swelling sits. So eccentric lytic lesion over in the medial tibial condyle. In the
there is a lytic lesion in the on the middle condyle, which is eccentrically placed. Okay. Then what about the margins?
Could you enlarge that picture, please? Thank you.
The margins of the swelling appears well defined. Sir, there is cortical thinning, and there appears to be cortical break, sir.
They appear to be cortical.
Sir, cortical break in the medial tibial condyle.
And what about the margins? You said it is.
Sir, well-defined margins. Sir.
Margins are relatively well defined. And is there any sclerosis?
Sir, there is a sclerosis of the margins.
Margins are sclerotic. And there is a soft tissue.
Sir, there is a
which appears in the APV. Okay. Now coming to lateral view.
Sir, lateral view, I can see the soft tissue shadow, and there is an erosion of the bone, sir.
On the anterior
on the anterior aspect, most probably the anterior medial aspect.
What has happened to the tibial tubercle?
Sir, tibial tubercle is less prominent.
How will you confirm that the tibial tubercle is getting eroded? Simple. An examination, the examiner might ask you.
Sir, making the patella tendon.
No, get an X-ray of the opposite knee. Because that will give us how much of the bone has been absorbed.
Okay, sir.
That is normal for him. Because it appears that the tibial tubercle has completely absorbed. I don't know. I may be wrong, but it looks like there is a big scalloped margin. Tibial tubercle is not seen. You can see a soft tissue shadow probably of the ligament patellae, but it is getting eroded. Now we are in a little more difficult terrain, not the bus cancerous burst.
So you cannot see the patellar tendon shadow. Instead, you can see the soft tissue overlapping that and eroding the anterior surface of the tibia. Okay, what about the matrix that is inside the joint? What do you from that? How can you? Yeah, you cannot call it as matrix, but what is the appearance inside? Again, the trabecular pattern. Okay, the trabecular portion, the trabecula is becoming is very obvious. While so there is a it simply shows it is just like what in the GCT happening. So in GCT, what happens is that it is not destroying, but the destroyed portion of the bone gives a false appearance of soap bubble. They are the remaining trabeculae that is giving a appearance of soap bubble. This is exactly what is happening here also. Even some of the trabeculae is very prominent, indicating that some erosion might have occurred. So because of that, the trabecula become very prominent. So in a way, it is a soap bubble appearance. It's not a typical, of course.
Okay, sir.
Again, the matrix, when you have somebody asks you what is the matrix, you can see the prominent trabeculae, which may be because of the destructive process occurring inside. That may be the better answer. Okay.
Could you focus on that AP view once again?
AP view.
Yeah, looking at that AP view, do you think that it is originally a soft tissue tumor eroding the bone, or a bony tumor eroding the soft tissue?
Sir, looking at X-ray, I said it is a bony swelling eroding the soft tissue, sir.
That's true. You have to now retrace what you have told about a Pessancerinus bursae alone, because it appears that there has been a fair amount of destruction, roughly about 3 centimeters or so, which has eroded into the soft tissue, and there is a huge soft tissue component also being seen. So the that was let out by erosion in the tibial tubercle. He said, I mean, the tibial chondri. If that was a palpatory finding, then you would not be surprised to see this X-ray.
Okay, sir.
But looking at the lateral view, sir, it looks more like a soft tissue eroding the bone.
That is true. That is just like our when you see a vertebral spine. I mean, vertebral thing, the so-called aneurysmal phenomenon which you see in the anterior body of is more or less like that in the lateral view. But looking at the medial tibial condyle, it appears it's not just true.
Yeah, if you are seeing the AP view, then we have to tell this is a bony lesion.
Yeah, because it cannot happen in 3 weeks.
That's right.
It appears a little longer duration. In 3 weeks, probably it has burst and then got into the soft tissue.
Yeah.
So,
Sir, looking at the X-ray, can we now take a differential diagnosis of GEOD?
definitely, because you have to ask 3 questions. Well, what is the lesion doing to the bone, and how is the lesion actually behaving? I mean, doing to the bone and the bone reacting to the lesion. That means there is definitely sclerosis on the superior and lateral border of the swelling. There is a definite sclerosis. but towards the lower part of the lesion, that is inferior portion, there is a crack in the bone, and that border is indistinct. It has broken down through the lower part of the tumor. It can be anything, but it appears that there is an indistinct margin towards the lower end. But the rest of the area is fully sclerosed, and the lateral view also confirms that it is fully sclerosed on the anterior aspect of the district. So whatever that was there is slowly has been there for some time, and it appears like this. So in an examination, you must be able to say that considering the nature of bone destruction, there is a cystic lesion in the metaphyseal region, which has probably eroded into the soft tissue and has produced a soft tissue swelling. It has become symptomatic in the last 3 weeks, probably because it has eroded and engrossed onto the soft tissue. So your diagnosis must now be a soft tissue infiltration following a bony tumor, and that's what I feel. I don't know what Dominic Sir thinks about it.
From the AP, looking at the AP alone, that is a possibility. But still, consider the lateral view also, which clearly erodes the bone. We can concentrate on the lateral side. Though there are lesions, which is the inside of the joint. What strike is the erosion of the anterior part of the tibia, and which is you can see the soft tissue shadow also corresponding to that. Lateral only confined here. Lateral view. So you can see the soft tissue shadow, which correspond to the area of the erosion. ഞാൻ അങ്ങനെ കാണിക്കുന്നത് കാണില്ല എന്ന് തോന്നുന്നു അല്ലേ? ഞാൻ എന്റെ ബ്രൗസർ കാണിക്കുന്നത് കാണില്ല ഇല്ല, അല്ലെങ്കിൽ അഭിലാഷ് കാണിച്ചേക്ക് ആ ഒരു ഭാഗം. That soft tissue is really eroding, and it is the inner portion which may be producing a radiological picture of a so probable appearance, which I have already told. Then Abhiraj was asking whether it is what you are saying.
Sir, considering the X-ray, can we take the diagnosis, differential diagnosis of geode, sir?
So that is the question. So they are the subchondral cysts. What is that?
Large subconscious cyst containing the synovial fluid.
But here, in that case, the margins will be very much sclerotic. Very much sclerotic. So it will not erode and go into the subcutaneous, into the soft tissues. It cannot, because there will be very thick margins all around. It will not go out. So, the lack of sclerosis on the medial side, and so much of it will not be present in the periphery. After all, it occurs in a weight-bearing area. What is the pathogenesis? When you break it is because of the degenerative changes, and the synovial fluid gets entrapped between the clefts and they get enlarged. So that will occur only in the weight-bearing area, not in the periphery like that. So this is in the periphery. So that cannot be your diagnosis. Of course, you are telling about the DD, that also can come to that picture. Okay.
Geode I will not consider, because it is actually a giant synovial cyst, subchondral synovial cyst. There it is actually eroding the bone. I will consider even the possibility of tuberculosis.
Yes.
Because there is no true expansion of the wall. There is a destruction of the wall. There is a sclerosis surrounding on the lateral aspect. There is sufficient soft tissue swelling. So the second possibility I will put is tuberculosis. Because in the earlier days, we used to see a number of cases in this region as cold abscess. Rising from the spine, coming through the saphenous nerve. And it actually bulges out on the medial aspect of the knee joint. So, second possibility, I will put it as tuberculosis.
Tuberculosis. I see. So, status pasarina and the second diagnosis tuberculosis. It may be tracking.
After seeing the X-ray, before the X-ray, I am also in favor of NSNS.
Yeah, that's right. Okay. So that is a possibility. Then
That
what is
explains the night pain also. That
And
will be explaining the
night
night pain.
pain also.
the pain also? Yeah, that's right.
But
Then-
tuberculous cold abscess producing erosion like this.
No, this is not a tuberculous cold abscess. This is tuberculosis of the medial tibial condyle.
Ah, right, okay. But that's one point I would object to that is there is sufficient sclerosis around it and there are no para-articular osteoporosis.
Sclerosis can be there in the healing phase. If there is a tendency for healing, you can have some sclerosis, natural healing.
If you ignore the destructive features, it looks like an osteoarthritic knee, that's all. It doesn't show any evidence of any.
Knee articular surface is normal.
Yeah, that's it. So it's the tuberculosis I will not consider, but because of the sclerosis, there are no para-articular osteoporosis.
I am not mentioning tuberculosis of the knee joint. Tuberculosis of the medial tibial condyle.
Yeah, that is the tuberculous bursitis.
Resultant and subsequently it has burst out.
That's true. And if you are saying tuberculosis, it is a tuberculous bursitis at the presencerens.
It could be that way also.
Yeah. But the point, if this swelling was present only for 3 weeks, that is the next question. Because 3 weeks, otherwise the history is wrong. If this is only 3 weeks, what I feel is there was a tumor in the medial femoral tibial condyle which burst in the last 3 weeks. And they started this thing. So I will vote for a tumor in the medial tibial condyle which has burst in the last 3 weeks and produced a collection in the pes anthracis. If that is 3 weeks, Abhilash, could you interrogate the patient very well? Did you actually interrogate him, not just ask?
Sir, he noticed, he was surely saying that he was noticed a swelling. The history was like this. He had a on and off knee pain of the medial side. It was not non-specific.
Very common for osteoarthritic knee.
For which he was giving hot baths. And while giving a hot bath, he noticed a small peanut-shaped swelling over the medial side of the knee, sir.
That is 3 weeks.
Sir, that was 1 month back. And it gradually increased in size for the past 2 weeks, and after 2 weeks, it's started getting.
All duration is limited to 1 month.
Yes, sir.
Right. So let us take a vote. Who believes that it originally started in tibia and went outside? I am voting for that. That's not the key because you have operated. So you keep quiet. Because you know what has happened.
Yeah, that's right. So I will be observed on the right side. That's right.
Kishore. Kishore,
Sir.
what is your cake? Is it Besancerinus eroding into the tibial tubercle?
I will give more weightage to the night pain, and seeing the X-ray and the cortical destruction and the soft tissue involvement, my diagnosis will be an infection, probably tuberculosis. That will be my first diagnosis. Second one, I will be even considering a malignant tumor.
Okay, so you are thinking in terms of tuberculosis and some sort of a sarcoma.
Yes.
Okay. Wilson sir, tuberculosis no?
I will consider GCT also. First.
GCT, yeah, that is okay. That I will definitely consider as a possibility because I said it is a tumor which has burst. Leo.
Yes, sir.
You take a case, this thing. Because now the opinion, ultimately speaker is Dominic. Because he knows what has happened.
I feel it's a soft tissue swelling which eroded the bone rather than a malignant bone tumor.
Okay, okay. That means video has come. Please. Diagnosis. Tony, what's your diagnosis? You are the next man.
Sir, after seeing the X-ray, the bony lesion extended to the soft tissue.
Okay, now Dominic can take over, please. I don't know what has happened.
Yeah, because we are just in the of it, it's better not to this at that time. I have seen it properly also. So I think you can have a better idea. You ask for a MRI. Okay, you can show a MRI.
Sir, hyperintensity lesion over the medial tibial condyle and associated bony erosion. Sir.
Is it a T1 weighted or a T2 weighted image? What are the images you are showing? In the pathology, you will be seeing in the T2 weighted images. Are you showing the T2 weighted images?
Sir, T2.
Okay. So, what are the findings?
Sir, there is a hyperintense lesion over the medial tibial condyle associated with the bony erosion. Sir.
So is it the expansion of the bone or is it erosion from outside?
Sir, it appears to be erosion from outside, sir. The
Right.
borders are well defined, sir.
But what is that? You cannot see any rim of bone outside or on the medial aspect. And in fact, the cortex is can be placed on the lateral aspect. Or the cortex can very well be placed on the inner lateral aspects. Okay. Anything very interesting on this field? Whatever is it entering into the joints?
Sir, there is, sir, in the down below images, there is a slight extension in the infrapatellar region. I cannot confirm it, sir.
I think there is a rim of bone joint from the swelling. Yes, there is no intra-articular extension. That is what I feel. The meniscus from this cut it looks normal. Okay, I can take one. Is there any other films? Here also, do you feel is it inside or outside the bone?
Sir, outside the bones.
So you can place the cortex all around. There is no ballooning, nothing like that. But there is a structure which is encircling that way, but it's a structure.
Sir, it's a medial collateral ligament most probably.
Yeah, the posterior part of the medial collateral ligament will be that is the one that is seen there. Okay. So after seeing the MRI, what do you feel?
Sir, I will stick on to my diagnosis of breast cancer in symbiosis.
Can you read the report? Can you show the report?
Sir, the impression of the MRI was osteoarthritis changes, upper epimetaphyseal eccentric T2 weight hyperintense and T1 hypointense lesion without significant post-contrast enhancement and shows associated periosseous component. Geode or a benign tumor like GCT ABC for clinical pathological correlation.
So for the reason I already told, geode is unlikely, and the giant cell tumor is something which because it is not from the at least from the MRI, I feel that it is not intra-articular. So except for there are 2 points. One is definitely the APVM, the X-ray, and the symptomatology is suggestive of intra-articular intraosseous lesion which is eroding, as Jayprasad said. But still, I didn't believe that MRI report, and still I feel it is only something S6 only, possibly a sensorina or a ganglion. That was my clinical impression, even after seeing the MRI report. Okay, but then that is my clinical impression. But ideally, we have to do what in such cases? How do you proceed?
Sir, I would like to do a biopsy.
Yeah. So what type of biopsy? What do you do?
As it is benign, appears to be a benign tumor, I will go for an excision biopsy.
But ideally, when somebody comes with a diagnosis of GCT and all these things, it is not it is safe to go for excision biopsy. It is better to at least aspirate, or if you feel it is not liquid, then you can have to take a focal biopsy. That is ideal. That must be the way you have to present. If you say excision, because you cannot, as Jabra sir also said, it's a GCT is a possibility, and APV will not show it is a soft tissue. It can very well be, and the sudden increase in the size, all are in favor of a condition like GCT with the soft tissue extension. So you cannot be very sure that it is a cyst outside the bone. So when you are asked, you have to say that you have to take a sugar biopsy. That will be the safer way of doing also. All this time made me think that it's only a bursa that is or a cyst, some cyst, a benign cyst, eroding the bone, and then you're almost sure. That is why I proceeded with the excision, though ideally I should not do that. Okay, you can show the palpoperative features. So you can just describe. Tony, you can tell because you are during the surgery. You are studying. We
So
try
first
to
we make the two skin markings after palpating the joint line, tibial tuberosity, and tendons. Then we put a skin incision over the centered over the swelling. It's a oblique skin incision centered over the swelling. Then we deepened the incision, and we found that a well-capsulated
then we identified one structure which we tried to say.
So we identified the infrapatellar branch of saphenous nerve, and we separated that.
You just keep it aside with safety. Yeah, okay.
Then we proceeded deeply and identified the well-capsulated soft tissue swellings with a jelly-like material inside it. And we curated it out.
And because as we are, as in the MRI show, it is going underneath the tibial collateral ligament. So we initially, we never decided not to remove it en masse, because if you are very particular to remove it en masse, inevitably we will damage the tibial collateral ligament. So we removed piecemeal. That was my decision also before surgery. So it is a jelly-like material. It is not, but the consistency is like that of a ganglion. But only this, it is more yellowish than the usual mucoid degeneration that occur in the ganglion. And we can see the thick capsule all around. And what was the undersurface of the
Sir, the tibial, proximal tibial, anteromedial surface of the proximal tibia were eroded by the this soft tissue. There were multiple irregularities over the proximal tibia without a destruction of the deep destruction.
Irregular, just destroyed in irregular fashion, which is it's like that, just like with some septa in between, exactly the way that is seen in the MRI also. MRI. So septations. So anyway, we are not expecting any other diagnosis, but still we have to wait for the biopsy.
Biopsy report ആയില്ല.
സാർ എക്സ്റേയില് നമ്മളൊരു കോർട്ടിക്കൽ ബ്രേക്ക് കണ്ടിട്ടുണ്ടായിരുന്നു സാർ, അത് ഓപ്പറേറ്റീവില് അപ്രീഷിയേറ്റ് ചെയ്യാൻ പറ്റുമോ?
അതാ പറഞ്ഞേ, ഈവൻ ഞാൻ നേരത്തെ പറഞ്ഞല്ലോ, സർജറിക്ക് മുമ്പ് തന്നെ ഞാൻ ടോണിക്ക് കാണിച്ചു കൊടുക്കുന്ന എന്റെ ഓർമ്മ. അതിങ്ങനെ ഫീൽ ചെയ്യുമ്പോ സ്വെല്ലിങ്ങിന്റെ അടിയിൽ ഇങ്ങനെ ഫീൽ ചെയ്യുമ്പോ ടിബിയ ഇറോഡറായിട്ട് കാണായിരുന്നു. എന്റെ ഓരോ ഘട്ടത്തിലും ആ ഇറോഷൻ കാണുമായിരുന്നു, ഭംഗിയായിട്ട് കാണുമായിരുന്നു. അപ്പോ എന്താ അബ്ജക്ഷൻ ചോദിച്ചെന്താ?
സാർ ഒരു കോർട്ടിക്കൽ ബ്രേക്ക് കണ്ടായിരുന്നു എക്സ്റേയില്.
അതെ, അത് ഇറോഷൻ കൊണ്ടുണ്ടാവുന്ന ബ്രേക്ക് തന്നെ ആയിരിക്കുള്ളൂ. ഒരു ഫോൾസ് ആയിട്ടുള്ള അപ്പിയറൻസ് ആയിരിക്കുള്ളൂ. ഇറോഷൻ അത് കോർട്ടിക്കൽ ബ്രേക്ക് കാണാം, പക്ഷെ അതൊരു തിൻ ഷെല്ല് അവിടെ ഓവർലാപ്പ് നിൽക്കണോണ്ടുണ്ടാവണ ഒരു സ്പീരിയസ് ആയിട്ടുള്ള അപ്പിയറൻസ് ആവുമെന്ന് ഞാൻ വിചാരിക്കുന്നത്. ഇതേപോലെ ഞാനൊരു എക്സാക്ട്ലി സെയിം ആയിട്ടുള്ള വേറെ കേസ് കണ്ടുകൊണ്ടാണ് എനിക്ക് ഇത്രയും കോൺഫിഡന്റ് ആയത്. Okay.
So have you taken any curettage from the bond inside the bond?
Curettage മെറ്റീരിയൽ ആയിട്ട് എടുത്തില്ല, പക്ഷെ ഇറ്റ് വെരി തിക് ബോൺ. ഭയങ്കര ഹാർഡ് ബോണായിരുന്നു. ക്യൂരറ്റ് ചെയ്യുമ്പോൾ സ്പെസിഫിക് ആയിട്ട് നമ്മൾ എടുത്തില്ല എന്നൊക്കെ തോന്നാം. അവസാനം ഉണ്ടായിരുന്നു അല്ലേ? നമ്മൾ ബോണായിട്ട് എടുക്കണം എന്ന് വിചാരിച്ചു, പക്ഷെ എടുത്തില്ല അല്ലേ ഡിജോ?
ബോണ്ടുള്ള ആ ഒരു സിസ്റ്റ് പോലെ നമ്മൾ ക്യൂർ ചെയ്തപ്പോൾ നേരെ ബോൺ ആ ഒരു സ്ക്ലിയോട്ടിക് ഇതാണ് കിട്ടിയത്. കോർട്ടെക്സ് ആ ഒരു ബോണ്ട് സ്ക്ലിയോട്ടിക് ആയിരുന്നു. പിന്നെ ആർട്ടിൽ സർഫസ് ഒരു കോണ്ടാക്ട് ഉള്ള പോലെ തോന്നി, ഒരു പെർഫറേഷൻ ഉള്ള പോലെ ഉണ്ടായിരുന്നു.
അവിടെ വരെ എത്തി. അതെ, അതായത് വി ക്യാൻ ഫീൽ ദാറ്റ് മിനിസ്കസ് ആ കോർട്ടിക് അവിടുത്തെ ബോണി കുറച്ച് റോൾ ചെയ്തിട്ട് കുറച്ച് സോഫ്റ്റ് ആയിരുന്നു. അപ്പോ ഇറ്റ് ഈസ് എ പോസിബിലിറ്റി ദാറ്റ് ഇറ്റ് ഈസ് അറൈസിംഗ് ഫ്രം ദ medial meniscus.
Meniscal tear is also there in the MRI, so there's a chance that it can be a meniscus. Possibility.
Considering the consistency of the material, could it be an intraosseous ganglion?
അതൊരു പോസിബിലിറ്റി സാറേ.
That's
right. അത് ഞങ്ങൾ ആലോചിച്ചില്ല.
Because the common side is lower end of tibia.
Yeah.
That I have seen. Lower end of tibia I have seen a few cases.
Yeah.
Can you show that dissected material once again?
Introsus ആണെങ്കിൽ it will be completely inside the bone അല്ലേ? അതിൽ പക്ഷേ ഒരു lateral side ഒട്ടും കവറേജ് ഉണ്ടായിരുന്നില്ല.
But at the advanced stages, one side may break.
അതെ.
The lateral lower tibial ഞാൻ കണ്ടിട്ടില്ല. Lower tibial I have seen it broken.
ശരിയാ സാർ.
I could even put a needle through that.
അപ്പൊ എനിക്ക് തോന്നുന്നു സാറ് പറഞ്ഞ ഇൻട്രോസിസ് ഗാംഗ്ലിയൻ ഇസ് എ വെരി ഗുഡ് പോസിബിലിറ്റി.
It's not such jelly-like material.
I have seen an intraosseous ganglion in the femoral condyle like this. A large sclerotic cystic lesion. It was actually എനിക്ക് തോന്നുന്നു MKBയുടെ കേസായിരുന്നു വിശ്വാൻ സാർ. സാറിന്റെ ആവുമ്പോ പിന്നെ നമുക്ക് ധൈര്യമായിട്ട് പറയാം. അത് again it goes back to the same system that there was something inside the bone which broke and then brought it. Otherwise his history is wrong. Then his history which we got is probably misled us, which is wrong. It will go well with the diagnosis of an intraosseous ganglion also. That way, it has worked recently and has created trouble. 3 weeks selling 1 month item. Slowly it has eroded and come out. And the presence of sclerosis is not against an intraosseous ganglion. The picture doesn't fit in with a giant cell tumor because he is 60 plus. Well, giant cell tumor should have been a little more earlier, 40s, etc. And females are more commonly seen. Of course, male also can be there, but they would probably go into this thing. We'll wait for the pathologist anyway. So now, intraosseous ganglion is a good possibility.
Looking back, intraosseous ganglion must be the first diagnosis എനിക്ക് തോന്നുന്നു.